is yours.
Thank you, Kristen, and thank you to our partners in the Emergency Management, Department of Emergency Management's Community Branch for your partnership on this. Good morning, I am Michael Pappas, and on behalf of the San Francisco Interfaith Council, I want to welcome you to this morning's online briefing for faith leaders. Faith leaders have an important and essential role in preparing their congregants and the community on the subject of advanced care planning. What could that role look like? What are some suggestions and solutions to this question? Given the current COVID-19 climate, these trainings and conversations seem more vital than ever. How might faith leaders assist in initiating discussions with their communities to engage in dialogue with hospital healthcare teams? How important is it for these two valued disciplines, clinicians as well as faith leaders, to have mutual respect for one another, for the good of patients and their families? How does the matter of racial inequities and healthcare disparities fit into this discussion? These questions and more will be at the heart of today's Essential Conversations online briefing for faith leaders, hosted by the San Francisco Interfaith Council in collaboration with the Department of Emergency Management's Community Branch. And now allow me to welcome the Chairman of the Board of the San Francisco Interfaith Council, Kaushik Roy.
Thank you, Michael. Good morning, everybody. On behalf of the Board of Directors of the Interfaith Council, I want to thank all of you for joining us, especially if there are any first-timers who are joining an Interfaith Council event for the first time. Welcome. As tradition has it, at the beginning of every Interfaith Council meeting or event, we start off by reading our Interfaith Council statement, which I will do now. This is an interfaith community. Whatever our individual belief, it can be freely expressed here with no apologies. If we are invited to offer a prayer in this setting, it should be offered according to the tradition with which we identify. If we are invited to speak on a subject from the perspective of our tradition, we are free to do so without fear of offending those who come from another tradition. We come together as people of faith to learn from each other that we might better understand the multiplicity of faith traditions in our city and in our world. Good morning, everybody.
Thank you, Kaushik. To ground us in a meditative moment, we welcome Father Greg Bonfiglio, the pastor of St. Ignatius Parish.
Good morning, everyone. I'm pleased to be here with you. Thank you, Michael, for asking me to do this. It's an honor to lead us in prayer this morning. I was asked to do, as Michael said, a meditation and a brief prayer, so we'll do those two pieces. I'll begin with a short meditation in silence for all of us, and then I'll conclude with a prayer. So I'll start by taking a few moments to recollect ourselves, and if it's helpful for you, I invite you to close your eyes. And let's begin by reviewing our day so far, reviewing your day, going back to the moment when you woke up this morning. What were your thoughts and feelings as you came to consciousness? Take some time now to review your preparations to start your day, to get ready for all that lies before you this morning, this afternoon, this evening. Who have been the people who have been part of the start of your day? And what were you feeling as you interacted with them, either about the person or about what you may have discussed? Have there been any insights or thoughts worth remembering? As you review these first hours thus far, what are you most grateful for? And take a moment to express your gratitude to God, however you name him or her. Who are the people or what are the concerns you carry in your heart this morning? Those that are on the forefront of your mind. Hold them up to God now and ask God to hold them, to bless them as they need. I invite you now to hold up to God those whom you serve, those whom you lead, those for whom you spend your life. And ask God to bless them. And ask God to bless you with gifts of wisdom and courage, strength and kindness, that you may continue to serve, to lead, and to spend your life. And let us now ask God to bless our time together this morning, that it be fruitful for the good of those we serve and for the common good of the citizens of our communities. Good and gracious God, source of all life, we come together this morning in the waning days of the season of Easter, as we prepare to celebrate the great festival of Pentecost, the sending of your Spirit. We are reminded once more of your deepest desires, to bestow new life upon all your creation, to heal, and to bind us all together, that we might live in joy and in peace. We thank you for that gift. As at that first Pentecost event when your Spirit united Parthians, Medes, and Elamites, Jews, Cretans, and Arabs, inhabitants of Mesopotamia, Judea, and Cappadocia, Pontus and Asia, Egypt, and Rome. Send your Spirit upon us this morning and unite us. Though we may speak in different tongues or images, help us to recognize the presence of your Spirit in one another. Bless us that we may be attentive to your truth and wisdom as you speak it through each among all. that we may better serve your people, our loved ones, those in need of care, especially those facing life decisions, those with whom we will have difficult conversations. Bless them all through our work today. We ask this through Christ our Lord. Amen.
Amen. Thank you, Father. That was beautiful. I would be remiss if I did not acknowledge two people who really were the inspiration of this program and also referred our guest speakers to us today. And that is, they are Karen McCoy Wade, the director of the California Department of Aging, and Shereen McSpadden, the director of the San Francisco Disabilities and Aging Services Department. The two of them from the outset really shared with us the importance of this issue of advanced care planning, and today is really the culmination, if you will, of their recommendations. So we thank them, and we thank our two guest presenters today. We are going to begin with Dr. Jessica Zitter, who is of renowned fame locally here in her work. Dr. Zitter specializes in critical care and palliative care medicine and practices at the public hospital in Oakland. She's the author of Extreme Measures, Finding a Better Path to the End of Life. Dr. Zitter, the floor is yours.
Oh, well, I am so tremendously honored to be here with you all in this time and to be presenting with my very good friend, Reverend Prilliet, with whom I've been working closely for a long time now on some of the work that you're about to hear and some of the essential conversations and how to expand those through our communities. I think you all know about the Alameda County Care Alliance, but I will quickly tell you, and I think Cynthia, when she starts talking, will be able to speak as well. But she has this beautiful group of people in Oakland who are trying to enhance the faith community in Oakland's understanding through educating the faith leaders to be more prepared for what is going on. Most lay people in general have really no preparation for what is happening in our hospitals and when people get sick and with advanced illness. And so Cynthia and her group have aimed to instruct the congregations through educating the faith leaders and bringing this understanding of what's happening in our healthcare system to the fore there. And so we started working together to try to bring the worlds of healthcare and the Alameda County Care Alliance's work together and to try to instruct the faith leaders from the ACCA in what these essential conversations are and how important it is that they be a part of them. And so what we've done is we've taken a movie that some of you may have seen called Extremis, which follows us around in the intensive care unit at Highland Hospital, and used it as an instructive tool to build a discussion guide that is really focused on educating faith leaders through the Alameda County Care Alliance. And there are the places that we've been doing most of the piloting is through their partnerships to really use images and experiences that happen in the film that are very captivating and very emotionally compelling to bring alive some of the issues that people are going to confront when they are faced with advanced illness. What is the end-of-life conveyor belt is something that we teach. This concept that I talk about a lot, where people come into a hospital and things happen automatically and with a sense of automaticity and by default. And so people all of a sudden with illness coming to the hospital for help are kind of hoisted onto this conveyor belt. And it happens in our intensive care units all around this country and treated very, very quickly with a whole variety of new and increased technological things to support their failing organs. And before they know it, and before they've had any voice in this matter, they are in a situation, many, where, and there's rising numbers of this, called chronic critical illness, where people essentially spend the rest of their lives attached to machines. And this is not something that people want. No one, and you look at surveys about how people want to live their lives, people don't want to live that way. And so they're just rising numbers of people in the United States for whom that is happening. And what Cynthia, I don't want to take Cynthia's time, but what they're really doing is trying to work within their faith community to address this issue, to educate the faith leaders, and then to make it so that these trusted faith leaders can be shepherds for their congregations about how to do this in a way that brings their preferences and values into all of what is going on in the hospital, instead of this default process of technology. So it's very exciting. It's something I'm very, very passionate about for everybody, but I'm particularly passionate when I think about the African American community, for whom racial inequities in healthcare are, especially at the end of life, in addition at the end of life, are very, very shocking and disturbing. There are many, many more African American patients die in this way that I've described on high technology without ever having been consulted about what is important to them than white people. And that inequity is just something that I find extremely disturbing, and I feel profound gratitude at the opportunity to work with Cynthia in her community to help try to right that in some way. So I think maybe I should turn it over to Cynthia at this point to give us more clarity about the Alameda County Care Alliance and some of the work that we've been actually doing with this discussion guide.
Thank you for that wonderful introduction of Cynthia.
Sorry.
No.
We love her so much.
No, you did it so much better than I could ever. We just want to welcome you, Dr. Perilliat.
Thank you so much, Michael and team. It's wonderful to be here. I certainly would be remiss if I didn't express my gratitude for this wonderful opportunity. And of course, my dear and wonderful friend and colleague, Dr. Jessica Zitter. It's always a joy for us to connect and work together and have these wonderful opportunities. Jessica has highlighted in a wonderful way and I have to say, I think it's pretty important work that we've undertaken as a team. And I will just add and highlight a bit more about the Alameda County Care Alliance. But even before I get to that, Michael, I have to just congratulate you and your wonderful organization. I am so thrilled for this opportunity to talk to the Interfaith Council of San Francisco, and just the incredible work that you all do and what you represent, and the fact that you bring this diversity of faith leaders together, and particularly for such a time as this. We salute you, and please continue to do this incredibly important work.
With your prayers.
Together, we can do great things. Thank you. So this work that Dr. Jessica and myself and our alliance, the Alameda County Care Alliance, let me step back for a moment and, if you will, and allow me to elaborate a bit more about the Care Alliance. This is basically and honestly a movement. And we began our very targeted and focused work back in 2013, where at the Allen Temple Baptist Church, Pastor J. Alfred Smith Jr. And some wonderful partners that are involved in not only the palliative care and hospice movement, but also healthcare as a whole, that are members of our church, but also members of the broader community, came together with a national organization called CTAC, which is, many of you may be aware of, the Coalition to Transform Advanced Care. And the entire notion was to bring together faith leaders from various traditions and perspectives across Northern California. And I believe some folks that are even on this wonderful Zoom call were even present and invited to the meeting. But the idea was to have various ethnicities, backgrounds, very diverse community of faith leaders to specifically talk about what do they see that their congregants and the broader community needs as it relates to supporting and caring for caregivers. And we also invited health system partners. So we had many of the wonderful health systems and insurers around the Northern California and Bay Area also present. And invariably, we left that opportunity. It was a day's work of interaction, very intense and dynamic communication, with this idea. Number one, we didn't want to spend our time with a lot of unfocused and unintentional meetings, that there are people, particularly caregivers, that are struggling, suffering in silence. There is a community of what we refer to as persons needing care. To folks in the healthcare systems, we often refer to them as patients, but we wanted to reframe the conversation so that people could be lifted up as valuable, as relevant and important in that particularly challenged part and time of their lives. And so out of that incredible kinds of needs assessment grew the Alameda County Care Alliance. And we basically, out of a group of about 60, again, interfaith leaders, health system partners, we walked away from that meeting saying that we were going to be very diligent and intentional about lifting up the voice of caregivers, lifting up the voice of persons that need care, and providing them with, and this is an important word, trusted resources, trusted partners that could literally walk with them in their challenge, often very challenging trajectory around advanced illness, serious chronic illnesses, and of course, ultimately end of life. And so I thought it was important to really set the stage and give you a sense on how we initially got together. My background, I have almost 30 years of involvement in hospice and palliative care from a training and market perspective. And I got involved when my dear father, Deacon Floyd Carter, Mount Zion Baptist Church, Toledo, Ohio, was diagnosed with 6 months to live at his first visit to his doctor as a result of some symptoms that he was very concerned about. And so that's important to share, because it was that personal experience that literally drove me to get deeply involved in this quote unquote advanced illness, palliative care, advanced care planning and discussions conversation. And it's important to note that our approach is holistic in nature. And so while we know the palliative care movement is very important, and literally we are a part of that movement, the interdisciplinary approach, mind, body, and spirit, and embracing the importance of all three, certainly for those that see the spiritual side of the entirety of being to be important and of relevance. We honor that. We sincerely honor that. And so it's important to note that this movement springs out of the multidisciplinary approach that palliative care speaks to, but also faith is not ashamed to lead the way. And so we, the leaders of the Alameda County Care Alliance, 5 churches started out with hub churches really being dedicated to addressing what we call 5 cornerstones, which are caregiving and caregivers, social needs, health needs, advanced care planning, and health. And so I hope that provides some foundation in terms of who we are, how we got started. Our relationship with Dr. Jessica Zitter has just been amazing and incredible. Jessica spoke about the wonderful Extremis documentary, and we have this amazing opportunity to not only have what we call community care navigators. These are trained individuals. These are paid positions. We also have volunteers, but these are paid positions. And these individuals are highly trained to have conversations around advanced care planning. But as Jessica alluded to, also our faith leaders, our pastors that are involved within our congregations to become cognizant further and deepen in their cognizance around advanced care planning, around the needs of people that have advanced illnesses and caregivers. But I'll stop there. There's much more to add, and I'm hoping that we can weave some of this really important detail around advanced care planning and how it's so important for faith leaders to see that this is our moment. We can literally reframe this incredibly important conversation around not just death, but a much broader conversation, and that is life and peace, and really what matters most.
Thank you, Reverend Perilliat and Dr. Zitter. We have three wonderful faith panelists that have joined us today. If there is nothing more to your presentation now, we would invite each of them to come and just talk about how COVID-19 has impacted their work, but then ask a question of you so that we can get your thoughts and illumination on these issues. Fair enough? Okay.
Thank you.
Okay, let us begin with the chaplain of the Institute on Aging, Rabbi Barnett Brickner. Rabbi Brickner is working intimately with a number of patients and clients who are at that very unique stage in life. And I know that this is an important part of his work. So Rabbi Brickner, would you share with us how the COVID-19 has impacted your work, what it was like before, after, and then ask a question of our guest presenters.
Sure. Again, I just want to echo the thanks and appreciation and gratitude for being part of this panel. It's an honor, and it's a very significant conversation to be part of. I have to tell you that since the lockdown and COVID-19, I've been more busy than I was prior to COVID-19 because everything seemed to just go on automatic at the Institute on Aging. And for those who are unaware of what the Institute on Aging is about, we are an organization that is working with elderly people with dementia and often with low to middle income families. The goal of our agency is to allow people to age in place with dignity for as long as possible. We also so we have multiple programs that address ways of helping people remain independent, remain self-sufficient, or and be able to live and stay in place, stay at home through their aging process. Mm-hmm. We also deal a lot with dementia. So we don't just deal with elderly as much as we deal with also people struggling with dementia of middle age or the like. My experience, because we don't have a place where people are actually like a hospital where they're in bed and you're doing rounds on floors and the like, and we have social workers and care providers that go to homes or go to RCFEs and the like. My work works mostly with social workers and the people that are the caregivers themselves. And what I have found is two things. One is a high anxiety around providing care for people, especially during this time. And also a internal high anxiety about how to address these very questions of end of life. Many social workers are really unprepared to have these conversations with the clients or the client's primary care providers. So I've been working extensively with our social workers and caregivers to help open up avenues to have those conversations and teach them the importance of allowing that space to have people express what they're feeling, what their preferences are, what their values are, much of what's in Dr. Zeitler's book, which I found very, very helpful. What I found also most intriguing is the profound fear that many social workers have around the subject of death and the subject of dying. And so the very most important thing, first thing I needed to do, was sort of break down that barrier of fear, because they just didn't want to address it. It would get too personal, it would get too emotional. And more importantly, it would get too theological, and they're just not ready because they themselves don't know. So one of the first things I do is address the question, what do you believe? I really believe that one can only have a conversation around death and dying if they themselves are comfortable in their own theology around that subject. So even if it's not it doesn't have to be formal or structured or graduate level. It just has to be gut feeling. What happens when you die? And how do you raise that question to somebody without being afraid of having to answer something you don't have the answer to? The reality is you don't have to have the answer. You just raise the question. I don't think there's a wrong answer to what happens when you die, because I've yet to see somebody come back and tell us. So, it's basically it's a worldview, it's a perspective. And then I also have encouraged people to help clients tell their story. I think that it's so important because everyone has a story and everyone has a story they want to tell. So for me, those are two really important foundations for helping open up conversations about death and dying. What do you believe? And you don't have to have the right answer, just gut feeling. And tell me who you are. How did you get here? What's your story? And when you open up those conversations, I think you loosen it up. You create an environment where people feel safer and can trust and are able to have the real conversations they reluctantly would avoid otherwise. So my question really is to both presenters. One of the struggles that I've also encountered, especially when I was in working as a hospital chaplain, was the conflict that existed between the medical team and the chaplaincy team. And back in the day, there was a real tension around the agenda and goals of medicine and the agenda and goals of pastoral care. And I found there was indeed an effort to try to bring the two closer together. And yet I wonder if I was curious if you could share what you find to be the current state of that relationship. Has there been, I know there's been efforts to improve the relationships, but I wonder how that has been going. I know that when I've been in medical ethics teams in hospitals, I often would find myself trying to mediate between a doctor and a patient or doctor-patient chaplain. And I'd like your feedback on that. Both of you.
Jessica, would you like to go first?
Sorry, I was muted. I would love to, if you'll permit me. I actually just sent to Karen in the chat an article that I wrote about doctors and chaplains and working together, and I have a lot to say about this topic.
You did.
What was that? Oh, I did. Right. Well, thank you for putting the question to me. I'm embarrassed to tell you how recently I have really started to understand, years into practicing as a palliative care doctor and understanding cognitively the importance of an interprofessional team. It makes perfect sense. It's all of the logic in the world. You want to be approaching people from a variety of different perspectives to really get the best understanding of them as a person. And I've been sitting around the table with chaplains and social workers for a long time, and it's really just too recent that I've really deeply begun to understand how important the work of a chaplain is. I mean, how in fact so much more important sometimes, many times, than what I'm doing. The hierarchy in the hospital is really embedded, and it is toxic, really, not only for the patients who end up having big parts of themselves unattended to and unconsidered, but also to the rest of us, because what we're trying to do is help without a full toolbox. And so when you really look at the data on spirituality, religiosity, desire of patients for attention to their spiritual sides, and you see what's actually happening in a hospital, which is essentially very little, if anything, you realize how off the mark we are. And it's only, again, too recently that I've started to really understand the power of us working together. And that is coming into a room and thinking about the spiritual side of a person first. I mean, unless somebody is clearly deteriorating and actively in pain, but really a person needs to be looked at as the most important parts of themselves. And for many people, that is their spiritual side. And it's not their lungs, and it's not their creatinine. And we're just missing the mark in medicine. So my goal and our future, one of our future plans with our project around using extremis and other modalities to teach faith leaders is then to bring that teaching back, have the faith leaders now come back and teach the doctors about, and other healthcare providers, but really mostly the doctors, because I think they're probably the most leverage, I'll put it in a nice way, to changing this. And so I think we really need to have more of a back and forth collaboration and teaching between faith leaders and doctors about how to do this better. I think that's all I'll say about this, but Cynthia?
Thank you for that, Jessica. I think it's a really key for me to say that you're looking at an incredible human being and a medical doctor, and Dr. Zitter, that in my mind represents really walking and talking what she really believes. And so around this subject of the collaboration between the medical and the spiritual, if you will, or doctors and faith leaders, Jessica walks the walk and talks the talk. She didn't mention Chaplain Betty Clark, but I know it was on her tongue or in her mind.
I just looked through to see if she's on the line, but she's not.
Jessica has embraced fully, and I've seen it in action, where in patient family scenarios, Jessica and Betty work hand in hand. They're like hand in glove. And in communities, not only in communities of color, African-American communities, various communities, these two work very collaboratively, if you will, to listen. Rabbi Bernie, you mentioned about storytelling and even story listening. And that's just a tremendously important part for effective relationships between patients, we refer to them as persons needing care, and caregivers, and that being many times family members. But I want to go back to your original question, Rabbi Barney, because I think it's an incredibly important question. There is a huge need, but also an incredible opportunity. And one of the tenets of the work that we engage in the Care Alliance is that important relationship between clinicians, physicians in particular, and also the faith community, pastors and faith leaders, is just tremendously important. Let's keep it real. Mutual respect. How important is that? That both of those important stakeholders recognize that simply by virtue of the roles that they play in the lives of the individuals that they care for and care about, they are both central and really want and need to be heard, but even broader than that, many times that their presence in the room together with family members is just tremendously important. We cannot afford to build this relationship. And I am thankful that we have this opportunity in working with Dr. Jessica and the Alameda County Care Alliance, with our pastors, with our care navigators, with our broader community, and Jessica and other physicians that we're working with within the community of Northern California here in particular, are really recognizing that together we can build the confidence, we can build a sense of hope. How important is hope? A sense of hope for patients and families and caregivers. And so one of the things that we've done is we have periodically pastor and clinician dinners, informal opportunities where pastors get to know clinicians, physicians, and physicians get to know pastors, and they talk about all the things they have in common. We know that faith leaders in many settings are viewed as gods, right? They're viewed as God. And physicians are many times viewed in similar ways. And that's just one example. And so we find that those two important stakeholders have much in common. We want to build mutual respect amongst them. And therefore, that energy, that love, that presence permeates to patients, persons needing care, and family members. And they feel certainly more cared for. And isn't that what this is all about? A community of gathering, hopeful, that life is important, and specifically that they are important. And I just want to piggyback on something that was said a little earlier. Many of our participants are low income, underserved communities, and how important is it for those precious individuals? Everyone is precious. Every person is precious. But isn't it important for those that are the least, the lowest, and the left out to know that there are people that care and that are there for them? And so this relationship between clinicians, pastors, faith leaders, spiritual leaders cannot be understated. It is tremendously important.
And
Thank you. The doctor of the soul has a lot to learn from the doctor of the body and vice versa. We have two more faith panelists that we need to give attention to. I'd like to now move us to a different setting. Now I'd like to take us to a different sacred place where people are navigating end of life, and that is in the hospice setting. In the city and county of San Francisco, what I have always known as Zen Hospice, now is the Zen Caregiving Project, has been that sacred place. It's been a place where those who are navigating the end weeks and months and days of their life are given not only dignity, but just that sacred space to journey with loved ones in a beautiful way. We are very blessed to have with us today Roy Raymer, who I know at least Cynthia Perilliet, Reverend Cynthia, you have worked with. Roy, would you kind of enlighten us as to your work, but also how it's been impacted by the COVID-19?
Thank you, Michael. Let's see, I am off mute. Yeah, it's wonderful to be here. It's actually my first time joining the Interfaith Council, so it's wonderful to be here, and thank you for the invitation. So I think I'll start with just very briefly, because I think this is really relevant to the conversation. For over 30 years, we were known as Zen Hospice Project. And while we're still serving people who are living with a terminal and chronic illness at Laguna Honda Hospital in the city, we no longer have our 6-bed residential care facility known as the guest house. And so when that change happened, we pivoted to supporting caregivers. And it felt really important to take many of the teachings that are foundational in our approach and offer those to both formal and informal caregivers. And what we found was that as we pushed upstream, as we say, to get caregivers and persons needing care earlier in the illness journey, the word hospice was a real barrier. So this is why we, while we're still officially legally Zen Hospice Project, we've rebranded ourselves, if you will, as Zen Caregiving Project. So, you know, confronting some people with the topic of death and dying and hospice still can be rather intimidating, if not irrelevant to them at their stage of caregiving. So in terms of COVID-19, we've been impacted in many ways, but just briefly, our volunteers are, of course, barred from being at the bedside at Laguna Honda. And we don't know how long that will go on for. We've certainly been impacted financially as a small nonprofit. Donations are down. Some of our work with partners has been interrupted because we can't be with them in person, but things are moving along. And so much of the work we do is engaging people in this conversation around death and dying, and inviting people to not just think about what they would like for themselves at the end of their life, but also what has been their relationship to death and loss up until this point in their lives. And this really goes to the question that I'd like to pose to Cynthia and to Jessica. And it kind of what Rabbi Barnett shared with us. He talked about working with the social workers and asking them what their theology is around death and dying. And so my question, I guess, is a little different. And that is, it seems to me, and I've observed this, that unless we do a thorough exploration of our own relationship to death and dying, it's really quite difficult to engage others in that conversation. As we know with this topic, our own grief and our own fears can get triggered rather easily when we venture into this territory. So I think my question is whether it's physicians or nurses or other paid caregivers, or faith leaders or care navigators, I'm curious to know how you invite them into this conversation. How do you invite them to do their own work, if you will, to really engage in an exploration of what their losses have been, and have they grieved their losses thoroughly, to better prepare them to hold space for people who perhaps haven't really explored this area fully enough and haven't considered what they'd like for themselves at the end of their lives. So I pose that to both of you.
Want to go, Cynthia?
It's like Cynthia's on
Oh, she's
mute.
muted.
Yeah.
It looks like she has something to say too. Oh, can someone unmute Cynthia?
There, oh,
There we go.
Can you hear me now?
Yeah.
Wonderful. Thank you. Roy, that is a really important question you raised. Thank you for that. And thank you for all the incredible work that you do. And the Zen Caregiving Project is just so important. Thank you for sharing where things are. And I'm hoping we all can contribute in various ways to help things become better, even in this COVID-19 climate that we're in. Hospice is very near and dear to my heart. I shared a bit about my story with my dad, and I was very aware that in the broader community, and very specifically in communities of color, when you speak the word hospice, as you mentioned, Roy, I mean, to people, you're simply saying death. You're actually, in many ways, it feels like you're speaking a death sentence over them. It's almost like, how dare you talk to me about hospice? Are you trying to say that I'm dying or my loved one is dying? And what gives you that right? I mean, it stirs and conjures, unfortunately, in many scenarios, a negative vibe, a negative impression. One of the ways that I have learned, experience remains a really good teacher, doesn't it? In making the shift from my training, marketing, and education background, my undergraduate work focused on niche, if you will, marketing, the importance of identifying and recognizing the value of community and all that it represents. We talk about person-centered approach to health and healthcare, but what does that really mean? It means embracing culture. It means embracing one's spirituality. Simply put, it means embracing the holistic nature of an individual. And so we have discovered that that is exactly the approach that gets the attention of very busy faith leaders, like all of you, that gets the attention of community leaders. When you're talking a holistic approach to care, Notice the word care, a broad sense of wholeness, mind, body, and spirit. And what are the needs of the people? What are those identified needs and how to address it from a holistic perspective? I found that that's when we get the attention of faith leaders. And so that's simply and really the targeted approach that we've taken in our work. And I would add that person-centered care, the model that we've been able to develop, I'm hoping we can continue this conversation because the idea is that the curriculum and the model that we've developed, we want it to be spread to the Latino community, to the Jewish community, to the German community, to the LGBT community. The idea is that each individual and who they are, who they see themselves are as human beings is what is important to be honored. So again, the approach, Roy, that works for us, and this is a part of the model that we would like to continue to replicate regionally and across the country, is that look at individuals from a perspective as a whole person. And when we approach individuals from that perspective, addressing not only their needs around serious and chronic illnesses and end of life, but also the fact that they are human beings and listening, it opens up the conversation. And therefore, they're more willing to talk about these issues around advanced care planning, around hospice, and the benefits that hospice can bring. There's so much that people don't know about hospice. And so we talk about the benefits of hospice. Many people don't know it's 100% covered by Medicare. Many people don't know Medi-Cal covers it 100%. Most insurances, at least 80%. I mean, there is a way to present this important subject and topic so that people can then begin to see that there is an opportunity for me here. And oh, by the way, we remind them that if you have a spiritual emphasis, you don't abandon it. That's the time to embrace it the more. And so we've been able to help people to see, and trust me, it's an ongoing movement. It's an ongoing war because we have to have more hands on deck. I call it the all hands on deck approach. There's something for everybody to do. Faith leaders are so important in being a part of this conversation, which is really why I'm really excited about being with you all today with Dr. Jessica, because we have to get our faith leaders to see they are such an integral part of this conversation. And we can be more active and more assertive. And I would say subtly, even more aggressive in initiating a holistic approach amongst our congregants in the community. I'm going to pass the baton to Dr. Jessica. We can't hear you, Jess.
Oh, now I can unmute myself. Well, I'm happy to talk, but I also want to be, I don't know, we have a third panelist, so I'm happy to, if we want to go into the third panelist, that's fine.
You're welcome to all chime in, please.
I'll give you 10 seconds, which is, yes, I think doctors, as a rule, are not comfortable with death, have a lot of death anxiety. Maybe that's even why we go into medicine. And one of the strategies that I know to enhance comfort with death is using stories. And the narrative medicine movement has shown us that it can actually make doctors and other healthcare providers who engage in it more comfortable with death, more willing to face it, and more empathic as well. That's another outcome that's been shown. And I think that's a big sort of learning strategy that we need to be using in medical schools and in other healthcare provider educational curricula. So that's what I'll say.
Thank you. And I just wanted to say, and I'll be betraying my age when I say this, but I did clinical pastoral education in the late 1980s at Mass General Hospital. And, part of it was tell your own story so that you're not projecting it on the patients. I remember telling my own story over and over, but I don't remember spending any time talking in particular about the issue of death. And that might be instructive both to physicians as well as to ongoing education for chaplains. I would just put that out there as you're reviewing your own curriculum. Our third panelist is a friend and colleague, Reverend Floyd Trammell. He is a member of the San Francisco Interfaith Council Board of Directors, pastor of First Friendship, but he's here today in his capacity as spiritual care manager at Zuckerberg San Francisco General Hospital. I have a great deal of respect for Reverend Floyd, and he has also worked with the palliative care group here in San Francisco too. So Reverend Floyd, the floor is yours.
First of all, thank you, Michael. Thank you for this opportunity, and it's really great hearing from Rabbi Barnett and Roy and Reverend Cynthia and Dr. Jessica. I count it an honor to be on this panel. Very briefly, I know I have 5 minutes. I'm going to try to capsulize this as best I can.
You're a Baptist pastor.
I want to sort of go to Rabbi Barnett because I am boots on the ground. I have not stopped working. So I've been going into COVID rooms and also seeing patients at the end of their life. I've been serving on the palliative care unit for palliative care team for the last 6 years. And just to sort of, Michael said, give a sense of how things are going. You know, when this first hit in general, there was a lot of fear, a lot of anxiety for the medical teams because of lack of PPE, people feeling threatened that they may get the disease themselves. So there's a lot of that. And, out of that came, more PPE, which, sort of slowed that down. And now, because of our mayor and Michael and all those who work behind the scenes, our numbers are dwindling, which is a positive thing. We're flattening the curve because of our discipline in staying home and wearing masks and washing our hands. So that's a good thing that we are seeing those changes with regards to the numbers, and that the numbers are definitely coming to that place. But I do want to say, with regards to this whole idea around advanced care planning, one thing I see, Rabbi, as you talk about walking around the floors, is there's this sense of death is a taboo. It's not a topic that you're going to go to Starbucks, or when you used to go to Starbucks or Pete's, and sit around the table and say, "Hey, everybody, let's talk about how you're going to die." Because we're prone to want to live, and so I think that conversation of itself is a taboo. What I find as my go-to when I'm talking to people is not so much of me talking about me, but me talking about them and hearing, trying to create a relationship. As you create a relationship with a family, or, and you talk to them and normalize their feelings, then it can open up an opportunity for you to talk about their loved one who is facing this terrible disease. And then bringing that family member alive and saying, what would they say? What would they want? Because in normalizing that, then they will, in real time, make their own advanced care decision for the patient. And I found that to be a very productive way of helping to manage, because we don't have, so many people do not have advanced care planning. And this is not just African Americans, it goes across the board where there's a lack of people who've done this. And so, it's a matter of really not going in there and saying, hey, let's start talking about advanced care planning in the first conversation. I mean, it's a matter of how do you build that relationship of just getting to know about the individual, their family, their background, and then getting them to talk about their person who is passing away and about who they are and what they did and things they enjoyed. And then you use that as the toolkit to say, now, if your family member loved to walk and loved to go outside, do you think they would really want to be in this situation? And most folks will be like, no, they wouldn't. And then they will make that decision themselves in real time of those decisions. And we've done that on several occasions. Not always successful. There's still some who want to go to the LTAC way. But on many times, we've been able to sort of be successful on that realm. And so I'll just say that, and I hope that's enough. I won't say any more, but I want to render this question to Reverend Cynthia and Dr. Jessica, and please forgive me for you not using your last names. I feel like we're informal, so I can I figure your first name is Doctor and Reverend, your last name's your first name. My question is this: how do we engage a marginalized communities to have this conversation around this topic of advanced care planning?
Cynthia, you want to go or do you want me to go?
Why don't you go first this time?
Well, there's, I think in some ways, Cynthia's better equipped to talk about the advanced care piece of it, the upstream piece of it, the before you get to the hospital piece of it. Can you hear me, by the way?
Absolutely.
Yes.
Okay. I will talk a little bit about the hospital piece really quickly, which is, Floyd, we're on a first name basis. I feel what's really critical, and what's really critical to teach healthcare teams is that all of the things that are in our agenda, like getting the code status and figuring out, are we doing this or not? Are we intubating or not? That is the less important part of the healthcare intervention. The more important part of the healthcare intervention is to show someone you care and to be interested and curious about them as a person and truly be interested, because the truth is people are interesting and fascinating. And there's a patient I'm actually going to be seeing later today who is very, very, very sick and probably dying. And it happened very fast. And I don't think she realizes it. And she's not very trusting and doesn't really want to hear that. And so we spent an hour and a half yesterday just becoming friends and just having her tell me a little bit about herself. And I'm not going to go in there really, even though she's actually very sick and there is a chance that maybe she could die. Maybe she could have died last night. I don't think so. But there's no benefit to going in and having an agenda from the healthcare perspective, the healthcare team, about what we're going to do and what is our plan, what is our medical decision, without a person being ready for it. So I'll let Cynthia talk about the more upstream pieces, but in the hospital, our goal, our job is to show people that we care about them, that we're not going to abandon them, that we're there for them, and we want to enhance and do things that are aligned with what they care about as people. Whatever their race, whatever their background, it doesn't matter.
Thank you for that, Jessica. Pastor Floyd, thank you for your work. You're at the General and doing great work. So thank you for that. I think your question is certainly one for us to consider broadly. So how do we get people to have this conversation, particularly from marginalized communities, is what I heard you raise. Did I get that right? Is that the essence of your question?
He can't talk.
You can't talk.
Yes, that's my question.
Okay. So let's speak from the perspective of being in the hospital, because I know that you're a pastor, so you're working both sides, if you will. You're both working within the institution of the hospital setting with the palliative care team, is what I heard, but you're also working in the community setting, which is tremendously important as well. I'll start from the hospital perspective, and Dr. Jessica was sharing about the conversations that she and her team are having and so forth. The upstream conversation, and that's why I'm so thrilled that we're having this discussion amongst the Interfaith Council leaders, is that we have to get our faith leaders to see that they are such an important stakeholder in community, in engaging community in these conversations of life, the trajectory of life, and the end of life. And it's inherent in who we are as faith people. The fragility of life. We talked about COVID-19. What a better opportunity. And I say that with chagrin, but it is an opportunity for us to begin to see that we have to deal with life in its magnificence, but it's also tremendously fragile. And COVID speaks to that fragility. It speaks to all that we don't know, the unknown. It speaks to the importance of embracing every single day. That's what we do as faith leaders. That's what we're all about. We're passionate about this stuff, right? And so one of the, I think, important purposes, and I know Jessica agrees with me, that one of our goals in this conversation is to get our leaders, all of us that are on this call and those that will hear this information, is to feel the need and fulfill the need in your own way, to make the move, to take courage, to engage in these conversations. And myself and Jessica, we are here. We're with you here in the Bay Area. We're happy to participate in engaging. How do we get folks to have these conversations? And so it's important to do it upstream. It's important to talk about the broadness of life. It's important to talk about COVID. This is our moment. We must take advantage of it and move forward in asking those difficult questions. And again, the fragility of life and what COVID says to individuals, it's an opportunity to get them to engage. Prior to COVID, as I was sharing a bit earlier, we take the approach that from a holistic perspective, what are the needs? Where are people? What are the needs of people? If we spring forth from the needs, then we will engage them because they have the sense, number one, that we care. Number two, that we're listening and we're asking the relevant questions. And so that's the approach that we've taken. And I have to say, and I'm really proud, I think a couple of our team members are on this call, that we've been able to, in the African American community, of course, nationally, we're about 12, 13% of the population, and about that number, 11 to 12% fill out advanced care directives. We have upward to 50% of our participants that are predominantly African American to fill out advanced directives. It's unheard of. But we're very proud to frankly boast of that statistic. The reason why we must share is that we believe in the training and the preparation of caring people, care navigators. These are not health professionals. Some are retired health professionals. Some are young, master degreed individuals that just have a compassion, a great compassion for people, and that are have social work background or have a nursing background. But the point is, there is a role for everybody, and community really wants to be engaged. We just need to raise the questions that deal with what are their needs, what are they struggling with, and expand that opportunity to continue and be consistent in showing that kind of care and that kind of collaboration. So it is a very thoughtful approach. It's an approach where pastors then see that their time isn't being wasted. Pastor Floyd, I know you get that side of it. There are tons of things that come across your desk every single day being embedded in community. And so pastors will embrace something that addresses all the intersections, if you will, social needs, directives as it relates to end-of-life care, caregiving needs. Where are my resources to help me to navigate health systems and broader community issues? And so it is an important topic of discussion, and faith leaders can play a significant role, not just issues around bereavement and the sick and shut in, and we engage them too in the conversation, but we must approach it from a holistic need perspective, which is very broad. People will then listen. Why? Because we are still, thank goodness, trusted entities. We're still trusted in our communities, and we cherish and we value that trust. It's important for us to engage.
Thank you so much. And this has been a very, very rich conversation. Reverend Cynthia, you said it's a conversation that needs to be ongoing. I almost feel like we've only just begun. So much has been said here today. We're at the end of our time. I want to say a very special thank you to Reverend Cynthia, Dr. Jessica, Rabbi Barney, Roy, and Reverend Floyd. And I think I would be remiss without saying that the San Francisco Interfaith Council, since the outset of the COVID pandemic, has been very intentional about praying for our healthcare providers, the hands of God at work, if you will, who are on the front lines. And we've also equally been very intentional about lifting up our hospital chaplains and CPE teams and healthcare workers who are pastoral healthcare workers who are also embedded within the hospitals, whose jobs have quite honestly become a little more challenging because other pastors and congregation leaders and faith leaders have not been able to get into the hospital settings to visit with their congregants. We pray for you all. We ask that you continue in this important work because it is so critical, especially at this time of the COVID-19. I just want to extend a couple more thanks. There's another Cynthia, and that is Cynthia Zambucas, who has is the Program Administrative Associate at the Interfaith Council, for her tireless efforts to help make these programs possible, as well as to our team at the San Francisco Department of Emergency Management. The coordinator of the community branch is John McKnight, and our lead production staff has been Kristen Lane. We have also on the team Sharon Walton, Karen Nemsek, and Rachel Schutt. We welcome you next week to join us. We will be talking about the impact of the COVID-19 on transit in San Francisco. We will be blessed to have with us the director of the San Francisco Municipal Transit Agency, Jeff Tumlin, and some wonderful faith participants who will also be bringing a perspective as well. This concludes our program. We will be sending out the recorded link to this with as well as resource links that we've asked our participants to share with us. And once again, thank you all so much for your gift of time and what you've shared with us today. You are part of the San Francisco Interfaith Council family. This concludes our program for the day.
Thank you so much.
Thank you. Thank you all.